I will tell you when you start recording, then you record.
Yes, yes, no problem. I will stop this recording just
Yeah,
now.
yeah,
Just
please,
you told me. And-
please.
Okay,
Should I
sir.
share?
Yes, sir. Yes, you can say.
So I hope you can see the first slide of death on operation table. Can you see that
No, sir. No,
now?
no, sir.
Because I have
Sir,
shared
sir.
now.
Yes, 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 yes. I see.
You are able to
Yes.
see?
Speed up. Yes, yes, yes.
Great. Now I'll move to second slide. This is my short introduction, MBBS MD Pediatrics LLB. Please take down my email address for communication, rajeevjoshi@gmail.com, and phone number 9822084614. Now, can you see next slide?
Yes, sir.
Okay, so that
Now
means
can
this is
start.
this all about. So we are all interested in safe delivery of anesthesia, and we are rarely prepared for demise of a patient. We want to prevent untoward outcomes. While anesthetic deaths are uncommon, we don't expect a death on table, and we will never be happy if such thing happens. Anesthetic death is defined as death occurring within 24 hours of administration of anesthesia due to causes related to anesthesia. It is as simple as that. You administer anesthesia to somebody, and somebody dies within 24 hours due to cause related to anesthesia, then probably this is death related to anesthesia, or it is anesthetic death. So they say that surgeon is caught at least once in lifetime in this tragedy, but the statistics would say that anesthetists would be facing such a situation more than a surgeon, because you are dealing with more complicated cases than an individual surgeon would do in his life, and you are also involved in ICU management as intensivist. So the risk that you take while inducing the patient and extubating and taking him out is much more than a surgeon would take during his surgery. So probably you are at much higher risk of meeting such situation day in and day out than the individual surgeons. So high risk events during surgery or anesthesia are at the time of induction, shift of anesthesia from SA to GA, at the time of extubation, shifting patient from OT. Now recently you might have heard there was one pediatrician in Pune, Dr. Sanjay Poddar, who underwent surgery for historical abscess, and saddle block was given to him. And after the surgery, he was shifted out, and his wife was there, anesthetic friends were there, physician was there, and immediately coming out of the OT, he collapsed and died. Nothing could be done. So these are the risks which even the patient is a doctor. These risks are there. Nothing can be done about it. Air CO2 insufflations. He was, by the way, very good friend of mine. He used to come to my hospital for exchange transfusion as and when required. And very thorough gentleman, interested in trekking, fitness freak, but the day had come and nothing could be done. So these are the high risk events that you are going through every day, and your patients are going through these events, and by God's grace, most of them come out uneventfully, but very few of them land into some difficulty. The statistics is that in cesarean section, 1 in 12,000, hysterectomy 1 in 4,000, laparoscopy 1 in 8,000, minor procedure 1 in 15,000. But is this gross underestimation? Do we really have statistics? Or these figures we get somewhere from the Western books? And in Indian situation, do we really have a statistics? That is my question. And being an informatics expert, I really feel that we really do not have any data on exactly what is happening around. But one thing is sure, that patient is having comorbidities, is having at higher risk of death on table. So that is one thing we should always keep in mind, and whether the patient has high risk factors or not should be one of the main concerns. Death is devastating. It's like an accident. It nobody can predict what will happen when. Somebody else can drive the truck on you, even if you are doing everything legal. So some risk factors or some host response in the patient may be responsible for an untold event which you are never expecting. Of course, it is more devastating if the patient is young, patient is healthy, the surgery is planned. Because if there is a roadside trauma, roadside accident, patient is already unconscious, he is brought to the theater, he is given anesthesia, people would not be shocked if the patient succumbs, whether because of anesthesia or because of bleeding or because of anything else. But if he is a young woman of 32 years old coming for a cesarean section and she goes through some complications, then definitely it will be a irreparable loss to the family. And we have to take all possible care to avoid that. Of course, even if you avoid, it's not very uh, guaranteed that the thing will happen. So death is devastating more so for the treating doctors. And some people told me that no, it's an occupational hazard. Everybody, a plumber would, electrician would fall, somebody will fall from the drainage and all those things. Similarly, doctors are facing this, but it's not like that. The issue is that in this case, someone else, a patient who comes to us with 100% trust and subjects his body in our hands, is dying or is facing consequences for which we are also not responsible, but still we go through emotional consequences. We don't know how to break the news. We don't know what stress will be in future. We lose confidence. There's a fear of loss of reputation, fear of stigmatization, fear of mob violence, fear of getting arrested. So all these fear factors were the ones which stimulated me to consult Dr. Uttam Shirarkar, who is an ENT surgeon turned psychologist for doctors, to give me some inputs on what are the solutions to counter these emotional consequences. Even though it is not part of anesthesia, but it is for the anesthetist that I'm going to talk in the last 5-10 minutes of this lecture. So it is a psychological framework. There are 4 phases of reaction: the kick, the fall, the recovery, and the long-term impact. And the health professionals are called as second victims. The second victims are healthcare providers who are involved in an unanticipated adverse patient event in the medical error and or patient-related injury and become victimized in the sense that the provider is traumatized by the event. That is called as second victim. Please remember this concept. You can read, Google it. A lot of materials available. I'll not go in much detail. So death is devastating more so for the treating doctors, not only because of the emotional consequences, because of the medical legal consequences also. So facing questions from the relatives: what happened, how happened, why happened, who is responsible, why it could not be avoided, all those things. Then there is an increasing need of meeting standard of care. But standard of care has become a golden word in the medical jurisprudence. That did you meet standard of care, and where is that standard of care written? Nobody knows. But then finally somebody will have to say that you made standard of care, and that is called as expert committee. And unfortunately, what we are seeing in the last few days or last few years is expert committees are not giving absolutely clear-cut opinion whether there was medical negligence or not, whether the standard of care was met or not. And you may be aware of a case in Pune in which anesthetist friend was helping the gynecologist couple on phone on how to manage the patient while he was driving from one hospital to their hospital. And unfortunately, he was also arrested along with the gynecologist because without seeing the patient, he was giving advice to the patient based on which the gynecologists were treating. So these are very, very important things, and we should be aware what we should be doing and what we should not be doing. Of course, we should be helping our fellow medical practitioners, that is for sure. Then how to handle police inquiry, there is increasing litigation from patients, increasing decisions in favor of patients, and increasing compensation amount. So if I were to go through medical legal suit, my life would be ruined because of the skyrocketing compensation amounts that are awarded by the courts. So that is what is the additional issue which we need to face, and we'll go about it in little more detail as we go along. So most important as far as operation theatre death is concerned, This, please remember this slide forever, because as patient's relative have no access to the operation theater, onus of proving that standard of care was met is with the treating doctors alone. Do you get this point? That because you don't let the patients come into the OT, which you will never allow, because that is a sterile and a place where you don't want people having no medical knowledge to be there. So, in view of that, the courts have given decisions which will come to that decision towards the end of this presentation, that since you do not allow access to the OT, onus of proving that standard of care was met is with the treating doctors alone. And now here, who are the treating doctors? The surgeon, the anesthetist, the assistant surgeon, the physician if is involved, nursing staff, and all those people. And through the evidence collected from all these people, the court is going to come to conclusion that the standard of care was met or not. So most important thing is your document, your case paper, that is going to be scrutinized, and we'll see how to go about that as we go along. So, okay, so there is a confusing terminology as far as entire gamut of complication. We call complication, someone else would call it as error. We say that it is an adverse event or reaction to a drug. People call it mistake. And who are these people? These are the lawyers. We say that this is act of God, this happened suddenly, it is an accident. They said that it is a fault, it is a negligence. And I'm going to tell you in 2 minutes where this negligence was started in the history of jurisprudence. There was a case in which a guy shot another person, and that another person was hospitalized. And then the defense lawyer said that if the doctor in the hospital would have treated patient properly, my client would have not gone for death penalty, he would have gone for life imprisonment. This was in UK. So he said that because of negligence of the doctor, the patient died. So to save his client from charge of murder, he charged the doctor for negligence. And that is how the initial history of medical negligence cases are started. So we have to be very careful, because the lawyers are going to twist and turn and take advantage of each and every line that you write in the case paper, or the evidence that comes through the assistants, through the surgeons, through the sisters, through everybody in the ward, and what document they will create will be more important than what document you produce. So that is how we have to look at the entire episode. So we have to first think of prevention. That is my first part of the introduction is over. I would wait for a minute here and ask if is there any query, or you want me to change the speed of the presentation, or you want any change. Doctor, can you tell me?
Nothing. I think in question box, nothing. Nobody's commented anything, and
There is
I
nothing in the
think you.
question box, right?
Yes, yes. So
So,
we are.
so we'll proceed. Okay. I'll
Yes, sir.
proceed.
Yes. Thank you, sir.
So prevention is the best solution for all the problems. And as I already said, that even if whatever you try, 100% prevention is not possible. But if you can reach 80%, 90%, 95%, we should try. So the moment you enter into the theater for giving anesthesia to the patient, you all do this. But let me say that it is my duty to say that this is to be done again where you are working, whether the hospital is registered or not. Because if you are working in the unregistered hospital, the negligence starts from there, from the entire team is working in the premises which are not registered, which don't have license, which are not recognized by the corporation. So first thing is you should be sure that the doctors are qualified. The qualification criteria is not determined by you or me or anybody. It is by the Maharashtra Medical Council or the medical or NMC, whichever may be the authority. Whether the OT infrastructure is proper, whether the gases are there, whether the theater has a ventilator, whether the theater has a defibrillator, whether emergency drugs are there in the tray, whether there is no expiry date of the drugs. All those things, it becomes a responsibility of the anesthetist to see that whatever is giving is not expiry drug, or the blood bags, if they are going to come, checking the blood, they are matching, cross matching, all those things are there. And before starting the surgery, right patient, right side, right procedure, all these are given in WHO guidelines. I don't need to repeat that, but still, this is my duty in the part of presentation prevention list. I have to give this checklist. Then this is my take on intraoperative prevention. I run a hospital. I'm a pediatrician. I see my wife who is a gynecologist operating every now and then. I see complications happening in the theater, and my interpretation is that if the surgeon is exhausted, if the anesthetist is exhausted, if the nurse is exhausted, please call for help. I'll give you one situation in which one of my friend's hospital, there was a leakage of oxygen cylinder. So he called me. I took cylinder from my hospital to his hospital, and there I saw that they were already operating for 4 hours for some complication, and the anesthetist had not even taken breakfast. She came there at 6 o'clock, and the surgery was supposed to be over by 7:30. So she had said, "Okay, I'll go home and have breakfast." But up to 10 o'clock, she had not had breakfast. So what I did at that time was I came back to my hospital, uh, arranged some breakfast for her, took it there, and then to call some other anesthetist to replace her for some time, and then she was relieved for half an hour. Then that surgery went on for the next 2 hours. So this is how we have to look into the problem, that if you are exhausted, tell somebody, call for help, get another anesthetist. If the surgeon, you feel that surgeon is exhausted, ask him first, do you want a replacement? Do you want any help? If you see a nurse in the hospital is exhausted, she may be committing some mistakes. So let us avoid the mistakes out of exhaustion, because they can be quickly corrected by replacing or stopping for some time. Or water may be the situation, water may be the solution, but that exhausted person should not continue to work. You may be able to work for 12 hours, but on one particular day you may have a small viral and then can't just work for even 2 hours. So you have to really think about this issue. And then about the patient, if the patient is bleeding, if there are BP changes, there are ICU changes, think whether you can abandon the procedure. If you can stop then and there. Procedure can be repeated after some days. Procedure can be postponed, but if there is a major issue, then there is no way back. So these are the 2 or 3 things about intraoperative prevention. One of the things which I have found is, if the time required for surgery is more than usual time for a particular surgery, maybe for a particular surgeon, it indicates that something is not right. One surgeon may take 45 minutes for LCS, another may take 1.5 hours for LCS, but the guy who is taking 1.5 hours, if he takes 3 hours, then something is definitely not right. So you have to really find out what is not right and whether that is going to affect the person, affect the patient, and any issue is going to be created. So now we talk about the situation. We have landed in the situation. There is flat line on ECG. This is going to give you goosebumps. Your heart rate is going to increase. You will start perspirating. You will be agitated. You will start yelling at somebody, give this me, give me that, give me that. This is the time where you have to control. This is the time where you have to start thinking of what next is to be done. These flat lines should initiate the thought process of preventing further damage to patient and to you and to your career. So the first duty is that, remember, the anesthetist is the one who will lead immediately. There will be set protocols for managing the cardiac arrest. Avoid prescribing life-saving drugs during emergency. Please do not write on prescription that get this drug from medical store and hand it over to the patient's relatives. Either you should have those drugs in your emergency box, or you ask your staff, your OT attendant, your sister to go to the medical store and get it, not in the hands of the relatives, because if they get inclination that this drug was not there in the hospital and afterwards it is proven that the necessary drug was not there, then you are in the big soup. Please remember that do not prescribe life-saving drugs during emergency. Either you have it in your box or you get it from nearby source. Call your friend, call your anesthetist friend, call your gynecologist friend, ask him to bring it from his hospital if it is there. There are so many hospitals nearby. We are competing so much that somebody else will quickly come in 5 minutes and give you the drug. Never, never, never write in the prescription and hand it over to the patient. Ask for help immediately. Please call your anesthesiologist friends and also surgeons having expertise in the same field. So, for example, the surgeon is gynecologist, call another gynecologist, the laparoscopic surgeon or the laparoscopic surgeon, because now we have got so much of the expertise and narrowing that one person from one field may not be able to secure or sort out issues in the other field. So you call, you are the anesthetist, you know many people. The surgeon may not be having comfortable relations with other surgeon of same type in same area, but you are going to various places, you call somebody, you take initiative, ask him, should I call that guy? Ask him who is the preferred person, but then you call that person immediately. That is essential. You need people, you need as many people as possible. Then this is a rule of CPR for 90 minutes. Patients have been revived at the end of 90 minutes also. There are papers, you can go on Google CPR for 90 minutes, you'll file some documentation. Most hospitals will stop at around 20 minutes. However, based on the results of studies, it is recommended to continue for at least 45 minutes, and patients have recovered after 90 minutes also. So try to use these 90 minutes in a profitable manner, as I'll tell you in next session. And then once there are 2 or 3 people around, maybe another anesthetist, another surgeon, someone else, some friend, please, please, please choose a leader and follow instructions of the team leader who has experience. She will divide tasks among the available members, and there are so many things to be done in those 90 minutes. So many things to be done. A leader is the one who knows the way, goes the way, and shows the way, and she will decide who should do what and do according to that to follow the protocol. Do not blame anybody in the theater. Not a sister, not an assistant, not the surgeon, not the anesthetist. Nobody is to be blamed. This is accident. This is accident. This has happened. Now we have to come out, all of us, from the accident, from the mishap. No point in blaming anyone. Do not blame anyone in the operation theater at time of mishap. I am repeating, no blame game, please. Now involve nursing staff. They should remain inside the theater. They should not get outside of it. Please involve nursing staff or all OT staff in the process of CPR, and also for administration of injections such as adrenaline, bicarb, calcium, whatnot. You tell them, you give this. They should have feeling that we have given this. Somebody else's, somebody's speaker is on. I'm getting sound of the cars and sirens. And can you please mute, sir? I'm getting
Yes, sir.
sound of the.
Muted, sir. Just now.
Can you please
Yes,
mute
sir. Yeah,
everybody
yeah.
else?
Yes,
Thank you.
yes. I did.
Thank
I
you.
did. Yes. Yes.
Okay. So you will involve all the OT staff in the process, because they should be able to go out and tell that we have given this, we have done that, we were involved, we have tried to save the patient. Not the anesthetist has tried, not the surgeon has tried. We have tried as a team. We have done this for you, because they are the ones with whom patients talk, not to the gynecologist, not to the surgeon, not to the anesthetist. So now you have realized that the patient is not likely to make it. So you have to break the news. Communication skill is most important. Please understand that person other than surgeon and anesthetist, other than surgeon and anesthetist, who can talk softly. You don't need to be very bold, very aggressive person. You need to have a very soft spoken person who invites 2 relatives in a calm and suitable room. Please see the bracket which I have written. The room should have 2 doors. It should have a broad table. The chair should be fixed. This is not from my own thinking. There is a one big article on how a theater, how a hospital should be designed for handling issues to avoid violence, to protect doctors. There should not be a paperweight there. Some nothing can be thrown at the hospitals. Not a chair. People, patients can lift a chair and hit you. Chair should be fixed. Table should be brought. Their hand should not reach you. There should be two doors. If required, you should be able to quickly get out of the door. Let the patients be there. You have to save yourself, but try and softly tell them that there is an issue. There is a situation. The person informs them that the patient is going downhill, not that there is a cardiac arrest, not that the patient has died, not that the patient is not going to come out. He will tell that patient is going downhill. Patient is going downhill, and treating doctors are taking all possible measures to help the patient to recover from the serious condition. We are taking efforts. We are trying to do all that is possible. He tells them that if necessary, they may invite some other relatives to the hospital. Don't try to hush up everything. You can talk to 10 people, but only two relatives at a time can talk to the doctors who will update periodically. So every 5 minutes, every 10 minutes, you will update. You have seen this being managed in big hospitals for big leaders. Somebody every 2 hours come out, gives medical bulletin. Follow that. Every 10 minutes, every 15, because you have only 90 minutes in your hands. In 10 minutes or 20 minutes, something, some information has to be given to the patients, and then you have to give information to the relatives regarding cause of becoming serious in language they can understand. The patient is old, there is an infection, there is high blood pressure, there is a low blood pressure, the heart has stopped, the patient could not tolerate surgery. Gradually tell them the patient is worsening, gradually, step by step, incrementally tell them that the patient is not making it. We are trying, we are giving treatment, we are giving this, we are giving that. The patient is not responding, patient is not able to tolerate this, patient is not going to probably come back. But we are trying, we are taking our efforts, we are doing whatever is possible. Continuously give this information at least every 15-20 minutes to the relatives in that room where you are protected. And I'm telling you, don't give them prescription for medicine, but give them prescription or check for the blood bag, which is to be brought from the blood bag in either your hospital or a nearby hospital. If there is excessive bleeding, there is a shock, there is a hypotension, relatives can bring back from a blood bank where the arrangement is already made, because in the initial slide we said that if there is a major surgery, you have already arranged the blood. If there is a LSCS, already arranged the blood. Even for normal delivery, you have already arranged the blood. So blood, wherever from it is there, they will bring it. This will help to create additional supporting evidence of efforts that you have taken. You wrote a blood sheet, you gave them, blood was brought, blood was given. That should be there in their mind that doctors are trying everything to be done. Everything is required to be done, doctors are doing. If by God's grace, the cardiac activity is seen on the monitor, then shift the patient to ICU after informing relatives about need of ICU management and taking consent with date and time. That at such and such time, patient's heart recovered, we have shifted the patient to ICU. Patients may be able to see the line on monitor. They don't understand whether it is good line or bad line. They can see that there is line or they will give you sign consent, and then you can shift the patient to the operation, from the operation theater to the ICU. If the cardiac activity is not seen on the monitor after 90 minutes or as per protocol of the hospital, take it from me, 20 minutes, you can't do all this. 20 minutes is too short a time. At least 45 minutes to 90 minutes, whatever period is in your hands, use it profitably, use it meticulously, and tell the patients now that you have to prepare yourself now to inform the relatives about the unfortunate death of the patient. So we come to now a mitigation plan. Patient has gone. You knew it 90 minutes ago. You were definitely sure about 60 minutes ago. And now between that period of 90 minutes, You have to take actions reducing the severity, seriousness, or pain of something, that something is trauma to you and your career and your money. You have to protect now your own interest. Patient has gone, nothing can be done about it. You have to protect yourself now. Please do not hesitate to do anything required to protect yourself. This, most of this is documentation. First thing is, before surgery, be sure that consent is taken. This is first plan of mitigation. Now remember that procedure consent should not have clause. I agree that there can be table that. I have seen hospitals where there is one sheet in which there are 8 consents from right from admission to table death. Everything is there. 8 consents are there. I told them, don't do this. They say, sir, every patient we take this consent. क्या होगा अभी कुछ होगा तो हमारे पास consent है. That doesn't work. Pre-printed standard consents have been taken as bad in law by Supreme Court of India. Don't use such consents. Consent should have table death consent if there is table death. Now I'll tell you, I had taken my 82-year-old relative to one of my friend who is an oncosurgeon, and the anesthetist said that, have you done color Doppler? We said, no, we have not done. He said, I will not give anesthesia without color Doppler study. He said that the patient is not able to eat, he has got tonsillar carcinoma, we have to remove, otherwise she is not able to eat. He said, I will not give anesthesia without having color Doppler. I said, I am willing to give consent on table death. He said, you will write consent on everything, I will not give anesthesia. So that should be your approach. If at all that emergency surgery is required, then you will have to give. But till that time, if it is required, you take consent for table death. But as far as possible, avoid to do such cases till you have minimum required investigations. In your own opinion, patient should be fit for the surgery. If at all surgery is required to be done in a serious condition, the cardiac output is not good, this is not there, but still surgery required, then you know that the patient is high risk and you take a table death consent. Consent must contain all the risk factors in the patient, all the risk factors. Each and every risk factors contributes the risk. Diabetes contributes, hypertension contributes, ISD contributes, everything contributes. All those things should be there in the consent. And anesthesia consent should be separate, and it should contain all possibilities. That is, change in type of anesthesia. Now, if there is general anesthesia, this may happen. Possibility of cardiac arrest, that all that things should be pre-printed. Doesn't matter because it is standard consent, not in the procedure consent. Okay, the consent is a contract between a doctor and a patient. It is freely given, it is reversible, it is informed consent. But once the procedure starts, then it cannot be reversed because the procedure already started and the contract has been implemented. So when the patient agrees to this, now during the 90 minutes of CPR, please remember this word, during 90 minutes of CPR, you have to complete your documentation. Confirm that pre and post-operative notes were taken, were written properly, ensure detailed cases is recorded, and all investigations is attached. They all should be there. If there is any lacuna, ask the treating doctor to write those things. There is some disturbance there. Okay, I'll continue.
Yes, sir. Yes.
Yeah. So diagnosis and plan of surgery, plan of procedure should be mentioned in the paper. Mention the operation notes, how unexpected turnaround took place, what treatment you gave. For example, suddenly patient started bleeding from so and so place, hemostasis was attempted, then it could not be done. That could be in a case of bleeding, or maybe in anesthesia, you can say that so and so thing happened, blood pressure dropped, I gave this, whatever you did, you write, and involve more specialists as soon as there is complication. More people are involved, more expertise you say, you will be considered to be more careful, more caring for the patient. You need to take experts along with you. Document everything that was done, all injections which were given chronologically, vitals recorded chronologically. Now you will not believe that the Supreme Court judgment says that every 5 minutes something has to be recorded. I'll come to that judgment later. Every 5 minutes something has to be recorded. Pulse, blood pressure, temperature, whatever. Every 5 minutes. And because they said the Harvard Medical School does that. We don't have that kind of luxury here, but still that is given in the Supreme Court judgment. So maybe when there is a situation, then you have to write 9.5, 9.10, 9.15, 9.20, whatever you have to write. Lab reports chronologically, if you have sent blood gases, electrolytes, send it couple of times, whatever may be the result, you have tried to do something, blood back checking and administer of blood products. And now these notes should be examined by other expert who has come there to your help. Okay? Some anesthetists should see anesthesia notes, some surgeons should see surgeon's notes, and these notes should be vetted, verified, because now after few minutes you are not going to have time. Your period is 90 minutes. No discrepancy should be there in the notes of surgeon, anesthetist, specialist, and nursing staff. In a Supreme Court case, it is noted that surgeon said that cardiac arrest happened in 15 minutes. The assistant surgeon said in 15 minutes, surgeon said in 30 minutes, anesthetist said in 40 minutes. So the moment there is incongruency, that means that somebody or other of these were not really taking care of the patient properly. Make them write their notes chronologically. Whosoever people are involved, they should be in chronological manner. Preferably, one person ensures chronology and others write their notes and sign. So if somebody maintains that 9.5 you write this, 9.5 you write that, you came at this time, you came in this, you did that, now write that. In those 90 minutes period, whatever was done, please, and then everybody does his job and signs his document, and then next step, like that you complete that document. And then cause of death. Now remember, this is 90 minutes is period after the event has happened, situation has arisen. Before that, surgery may be going on for 2 hours. Nobody is writing anything for those 2 hours, but those 2 hours notes also should be there. What we did from the time of induction of anesthesia till the event happened and after the event happened, everything should be there, including the cause of death. Now, the cause of death you have to all agree upon before writing the cause of death. If it is known and it is agreed, then post-mortem is not mandatory. You can give the cause of death. However, even if known, relatives can be offered to ask for post-mortem if they so wish. In India, fortunately, nobody wishes. We'll come to that later. If not known, better not to commit in writing, differentiate in cause of death, revealed during difference in the cause of death revealed during post-mortem and your cause of death may create problems at later date. If you don't know, don't write. Patient has come to you serious in shock. You have opened for exploratory laparotomy. You have already opened for exploratory laparotomy. You don't know the cause. Then you have to write it. Don't give it. Let it be found by the post-mortem. No need for doing something going beyond or out of the way to save post-mortem of the patient. If it is easily possible, yes, do it. If it is not, don't go out of the way. Avoid common mistakes regarding case papers and the notes. They should not look visibly manipulated. They should not be too perfect. Omission of obvious steps should not be there. Notes should not be contradictory. There should not be more than one set of notes. It will so happen that you have written something that you wanted to scratch something, then you started writing one more paper again, and you have to tear out that first paper. Remember that, tear it out and throw it out. Throw it out of the operation theatre, not in the dustbin of the operation theatre, out of the operation theatre. Consent is not taken, minor surgery is taken lightly. So these things you have to avoid. And before 90 minutes, whatever drugs you give, ampoules of all used drugs should be thrown in the dustbin along with glove covers and other disposable material. There should be no drug crossing expiry date in the OT and in the dustbin. Please ensure that nothing is there in the dustbin which has expired. Even if the surgery before you might have used the drug, please remove it. Take that care. Because if somebody finds that you used expired drug for somebody, then you will have it. That is 100% negligence according to the opposite party lawyer. He is going to be involved if at all there is a litigation. Leave the things as they are. Do not clear the OT. Do not, suppose there are blood stains, suppose there are cloths, your drapes lying down, whatever it is, keep it like that. Get out when you are supposed to get out. During these 90 minutes of CPR, give clear instructions for your junior staff not to talk, no comments outside the theatre. No comments from nursing staff, no comments from anyone other than communicator spokesperson. Nobody should talk. However, please ensure that you do debriefing to the OT staff regarding what happened, what was your diagnosis, what treatment you tried, what happened, why the patient became serious. They should know, because these questions will be asked to them, and if they say we don't know, it will look as they are hushing up. So they will tell what you want them to tell, and they will tell. Even if you don't tell, if you tell them no comments, they will tell. Even if you tell them only designated person should talk to the relatives, they will talk. But then they should talk what you want them to talk, not something which they feel. So what they should talk should be told them in debriefing. And now, please forgive me for using this slide, but you will remember this slide. वो 70 मिनट, ये 70 मिनट आप जो करना चाहोगे वो करो. Whatever that he has said, I am telling you, these 90 minutes are the ones which are going to save you from so many things in future. These 90 minutes use very properly. And please remember this slide, if not anything else from this lecture, that those 90 minutes are crucial for you. Now we have reached the stage of communication with the patient. This slide shows so much of a jargon, information, speak, sound, talk, shout, all those things. This is all going to happen when you start communicating about the death. Expect this. This is going to happen. The breaking the news of the death of the patient is very difficult for anyone, preferably treating surgeon and anesthetist. They should not be seen to be running away from the reality. They should talk. If they have some fear, if they are aggressive in nature, then better to be doing it with communicator or spokesperson who know how to talk. Then they will talk and you will be there, but you will be there. You should be there, and you should be passionate, you should be compassionate, you should show that you care, but you could not do anything. You are sorry about the situation. You are not sorry about what you did. You are sorry that the patient's relative has expired. You feel bad. Not sorry means you ask for apology. You say that you feel sorry. You are unhappy. You anticipate reactions of the relatives and handle it well. You have to anticipate the reactions of the relatives and you have to handle it well. There is going to be reaction. Be prepared for shock, pain, anger. They will be shocked, obviously. The relatives will be shocked. Even if you have told them that the patient is going downhill and you are trying to do everything, the fact that you could not do anything or you could not save the patient is a shocking and painful event for the relatives. Even if you are at their place, you will also feel bad, you will be shocked, you will be having pain, you will be angry, the relatives will be angry. You have to calm them down somehow. Being angry is better than their feeling guilt that they should have done something. They're going into depression because that may bounce back and then they may, take out all that anger on you. So if they are feeling guilty, you have to be very compassionate. If they are depressed, you have to be very compassionate. If they are angry, by using mild words, soft words, kindness, you can get that anger down because you have been telling them for 90 minutes that the patient is going down. Gradually, they are also making up their mind somehow, but still that trigger is going to be there and that has to be handled very nicely. Expect abuse, assault, attack, and action. That is legal action. Expect abuse, assault, attack, and action. Now, this slide is showing you advocates ransacking a hospital. 3 patients die as 250 lawyers are charged over ransacking hospital. But this is in Pakistan. Thankfully, we are not yet there. Our lawyers are much well behaved. But still, this is what is there. You have lawyers, they decide nothing. I mean, they will be able to sort of take you for a task and just be very polite with them as and when there is an issue. And now you are seeing on your television that in Ukraine, people are using the sandbags to protect themselves. Similarly, you had to be prepared for request for documents, inquiry by police, and prevention of arrest. So this is very important. You have to be prepared for this. This may not happen, but you have to be prepared for this. So for the documents, please note that if the patients request documents in writing, you have to give in 72 hours time. You have 72 hours. However, if the police are involved, they can confiscate the original documents. So before the intimation goes to police, your document should be ready. Keep detailed case paper ready. Hand over numbered pages of full case paper. Please number that case paper there and there. All the investigation reports, all the lab tests, all blood given, not given, whatever it is. 1 to 20, 1 to 40, whatever that number is, 1 to 20, 1 to 40 numbering should be there. And get photocopies after numbering. If relatives are going to be asking, give them photocopy and take acknowledgement on other photocopy. If police is taking originals, take acknowledgement on photocopy. Take signature of recipient on photocopy, whether police or relatives. And from patient's relatives, take signature on demand letter also. The patient has demanded on 1st of March and you have given the documents on 4th of March. That should be the conclusion from that document. Patient demanded, when the patient has signed on 1st of March and delivered a document to you on 2nd of March, you write that you received on 2nd of March and then you delivered on 5th of March. Those things should be there. Please remember that whatever done is in the past will be taken at face value by the court. But then you should have done it on those days. Okay. So take signature on the demand letter also. And now you will be ready for inquiry by the police, if at all police is involved. So the inquiry by police may be, they will take statements of patients' relatives, they will take statements of doctors, and they may take statement of staff. So when you have trained the staff what to talk, they will talk that and that will be recorded. Case paper will be collected by police, usually original copy. Do not move body or destroy drugs, IV bottles, blood bags, etc. unless police arrive and they permit you. Panchanama is essential part of police service. Not that all this is going to lead to a litigation or a case because that is their job. Preoperative deaths are in perioperative, all perioperative deaths are included. There is no written rule to say that PM is mandatory. The police themselves can say that postmortem is not required. Say suppose there is an 82-year-old person who has undergone a major surgery in your hospital and relatives have no problem. You have told them what has happened and they are calm and quiet, then they will not insist on PM. Shifting involved on ventilator and declaration afterwards does not change the position. Criminal case differs from case in consumer redress forum. These are the more nitty-gritties of the law. Let's not get into those details just now. But now you have to prepare for prevention of arrest also. This is very important. Keep copies of this judgment in the hospital, which should be available immediately. Jacob Matthews, I have given the citation. Arrest can be done only after obtaining report from expert committee, preferably from government hospital. Now there are two types of expert committee. District hospitals have got one type of expert committee, and districts which have medical college have other type of expert committee. We are fighting in the court regarding this issue that all these expert committees should be same. Both should have medical MMC member. District committee has one, medical college committee doesn't have one. We are saying that both should have because nowadays expert committees are not giving proper outcome or reports or proper opinions. In Lalita Kumari, they have said that FIR may be filed after preliminary inquiry. And now you will not believe, in a case which I argued in the High Court of Bombay, the Chief Justice asked the Advocate General of Maharashtra State whether you know Lalita Kumari judgment, and Advocate General said that I don't know. So if the Advocate General says I don't know, then the police is also not supposed to know. So you are supposed to keep the judgments in your hospital and give copy of that judgment to the police and tell them that 120.6 in Lalita Kumari says that these are the episodes in which preliminary inquiry should be made before arrest or before FIR, matrimonial disputes, commercial offense, medical negligence cases. And believe me, Chief Justice of Bombay said that ABC sees medical negligence. He knew this judgment by heart. and Advocate General did not know this. Corruption cases and cases where there is a whatever delay. So this judgment copy should be there in your office, in your hospital, and hand it over to the police and tell them that before preliminary inquiry you cannot file FIR, before expert committee report you cannot arrest doctors, and then you have some more time so that your arrest is prevented. And now we get into the process of litigation. If at all it is going to be there, get into the process of litigation, and you can see so many agencies get involved once that litigation process starts. The litigant, the judiciary, the attorney, the criminal lawyer, the government, the judge, so many things. Then there's a judgment, there's a verdict, then there's punishment. So this is a big jargon which we would never want to go through, but we are going to be forced through it if we are not very careful. There are contradictory views. Intimation of police, MLC and PM. Some will tell you advisable to inform police. Some will tell you inform police only if relatives insist. Some will tell you make MLC and insist of PM. Some people will tell you MLC and PM are not necessary as per law. Some will tell you it is more important in case of blind procedure, D&C's copy. No PM, it is difficult to defend, and some will tell you that if cause of death is known, doctors can say. So this is a question of to be or not to be, and that question I think every hospital has to address as per its own administrative policies. But for me, I would always say that informing the police yourself is the best strategy, though there is difference of opinion. I will tell you the reason why. If the patient's relatives file a complaint against you, and they put a clause of murder or 3041, 3042, then police will come with that complaint. It is better that you file a complaint and tell them that this is a 304A. I'll tell you the difference between the two. Inform when violence is imminent. You feel that patients are agitated, they will bring 20 people, they will try to break the hospital, they will hit you. Better that you tell the police and you avoid injury and loss of property. Whatever litigation is going to be there, let it be afterwards. If you are not injured, if your hospital property is not damaged, then many things can be done later on, but at least avoid injury. So I always feel that many hospitals try not to invite police. Even if police comes, they try to hush up the things, which is not correct in the longer run. Inform the control room, call that 101 or whatever 1110, whatever number is there. Take down the buckle number and note it on the case paper with date and time that you have in for this buckle number at this time on this date, and your job of intimation to the police is over. Now face police inquiry very politely with confidence. You should not sound arrogant. You should be confident but not arrogant. There is a thin line. Be polite. They should never feel that you will run away. They should never feel that you are not cooperating. These two are the reasons for arrest as per Jacob Matthews and Lalita Kumar. Even if they say that do not arrest doctors, they say that if police feels that doctor is not available for the inquiry or he will run away, he will not cooperate, and they can arrest. So don't give this chance to the police. The arrest is usually technical. Bail is the rule and usually granted under section 304A. Normally, police is not interested in arresting you or doing anything with you. They are not interested in doing anything with the case. They don't want to do work. But if you stimulate, if you instigate them to work, then they will work. But complaint filing is not instigation. You call them, tell them what has happened. There is a dead body, whether to go for post-mortem. Those decisions are to be taken. About post-mortem. Now you all know that Indian minds resist autopsies. We don't want to go for post-mortem. We want the body intact and do the rituals. So if you are sure about cause of death, if you know why the patient died, the roadside accident, patient bled and came in shock and nothing could be done. 82-year-old person came in severe abdominal pain, pancreatitis or CA pancreas, whatever was tried to be done was done but could not be done. Patient could not survive. So you can give death certificate if you are sure about the cause of death, and then you take undertaking from relatives with witnesses that the DC is given in good faith on our request to avoid post-mortem. We have been told about advisability of post-mortem. We have been told that PM may be obtained even after giving DC because you are sure about the diagnosis. Why you should be afraid of DC? If you are trying to help the patient, give the diagnosis, and after giving the DC, handing over the body to them. If they want, they can go for postmortem, but then you insist on two doctors doing it or video filming, but that you demand in writing and ask before the process starts. So you should keep track on what is happening, whether the body is going to be taken to the postmortem or to the morgue. You have to follow that up. At least talk conversation with the patients or their relatives. Now, coming to the sections. Section 301 and 302 are intention of causing harm and knowledge of causing death. Now, these two sections are not applicable to us, but police apply. Because we have knowledge that doing certain thing causes death or may cause death. Giving anesthetic drug may cause death. That you know, everybody knows, and they put that clause. Okay, this is not correct, but they put the clause because they want to show that they have done something. You have to tell them that this is actually 304A, which is dead due to the alleged negligence. Patients' relatives are saying that doctor has not given proper treatment, alleged negligence. 304A is bailable offense. So for that much, if you study Indian Penal Code 1860, read only these three sections, keep a copy of those sections with you, you will be better off if you teach people something about law than police teaching you about law. And now let us come to burden of proof. Burden of proof means something, onus of proving the allegation. Now, if I allege that you have stolen my wallet, then it is my job to prove that you have stolen it. Okay. So in ordinary case, it is for the complainant to prove that negligence was done by the doctor, and this is the reason why I tell you don't give prescription of medicine to the patient's relatives hand, because then they will say that doctors did not have the drug when it was required, and 15 minutes were passed between our getting the chit and getting the drug, and in those 15 minutes patient was harmed. So there is a proof of negligence in our hands. So we have to avoid that situation. In death on table, the doctor has to explain how he was not negligent. What was the diagnosis in the patient? What were the risk factors? What were the findings? What was the diagnosis? What he did? And he has tried to do everything. He has taken standard care. What is supposed to be done? What drugs were supposed to be given? Have we given? And he can prove that it was a mishap. Nothing could be done. It was an accident. And the outcome was unfavorable, even though all that was tried to do. But that has to come out from your documents. You have to prove it. Your documents, if they are incongruent, if they are having contradictory statements, then your document will be against you. So your document has to be perfect. So in those 90 minutes, you have to make effort that the document is perfect. Now comes the question, because this is a group of anesthetists, I have got this judgment, trust me, Fadnavis versus Mumbai Grak Panchayat. In this, whether there is a liability of anesthetist or not is discussed, and anesthetist is held to be liable even though he has not made any direct contract with the patient. The surgeon has told that this will cost you 25,000 rupees and I will treat you, and if by God's grace patient goes home, surgeon takes 25,000 and pays his check to anesthetist. However, even if the services of the anesthetist were hired by the surgeon, opposite party one, then also deceased happened to be the beneficiary of medical service of the anesthetist, because he was going to be paid by the surgeon later on. And hence the consumer and that service of the anesthetist are invariably paid by for the patients themselves, their charges being generally shown separately in the bill. So anesthetist charges are shown separately in the bill, whether 30% of surgeon charges or 25% of surgeon charges, immaterial. Don't you cannot create any issue about it that normally I am paid 30%, but this surgeon pays only 15%, so I am not liable. Nothing doing. If you are paid for that service, you are going to be liable for the charges along with the surgeon. And now I am going to discuss this case in detail. Aruna Ben, D. Kothari and other sources, Navdeep Clinic and others. I hope we have adequate time with us. Dr. Chandolkar?
Yes, sir. Yes, sir.
Yeah.
We have, sir. Yes.
Yeah. So now, actually, I want to thank Dr. Chandolkar because he suggested that you at least give one detailed case with compensation and all that. So this is a case due to cardiorespiratory arrest, compensation of 4,20,000 plus interest is awarded. Now see, now retrospectively, this is 1995 or 96 case, but see retrospectively how this case has come up. Complications and death of patient occurred in four walls of operation theatre, where patient's relatives had no access whatsoever, and owners therefore should lie on the doctors in the operation theatre. Now see what doctors in the operation theatre have done. Dr. Rashmi Vora, orthopedic surgeon, was charged to pay 30% of the compensation. Why? Orthopedic surgeon who operated on the patient says that surgery was minor and cardiac arrest could have been due to anesthesia. But Dr. Vora decides which physician to call, which anesthetist to call, when, where, and how to operate. So she is liable. In present case, choice of anesthetist was that of Dr. Rashmi Vora, and patient had no say in it. Therefore, the act of anesthetist involves the responsibility of Dr. Vora also. Cardiac surgeon cannot run away from the responsibility. 30% of the responsibility is with the surgeon. Dr. Meenakshi Ben was anesthetist. She says that I do not think surgical procedure as a cause of cardiac arrest. But she is not in a position to say why cardiac arrest occurred. She says it is the duty of the surgeon to provide defibrillator in the operation theatre. And the court says that she should have procured the same as a precaution before starting anesthesia, or could have refused to give anesthesia without said machine. If defibrillator was not there, if it was not working, you should not have given anesthesia. The very fact that you gave anesthesia means that you took responsibility and you did professionally incorrect job. And this is one very funny thing. Dr. Desai, who is a physician, who took a cardiogram and gave a fitness certificate for surgery in spite of blood pressure of 150 by 100. And there were STD changes also in the ECG. In addition, after that he issued death certificate even though he came to the OT after the death. This certainly can be said to an act of omission for which he is squarely answerable, but he has failed to do so, and therefore it can be assumed that he acted in negligent manner. 10% liability. Now, if the ECG showed abnormality, why anesthetist gave anesthesia? If the blood pressure was 150 by 100, why anesthetist did not take preventive measure? If there are STD changes, what did anesthetist do? So anesthetist is liable for 60% in this particular case. Now, we have seen all this in our first part of the lecture, that all this care we have to take before we induce the patient. Once you have committed, then you cannot come back and say that I am not responsible. Responsibility is to be taken before induction of the anesthesia. So these people went into appeal. And in appeal, the Supreme Court has said that between 9 a.m. and 9:40 a.m., except for the administration of anesthesia, nothing else is mentioned in the hospital record. Every 5-minute blood pressure record is required as per Harvard Medical School. Okay. In this file, an apparent non-action is correlated to the prescribed monitoring and also crucial to 3 to 5 minutes, which stand between life and death of a patient for non-supply of oxygen. This monitoring was of great significance, of which no record is available. So even if you have not written at that time, please, please, please write afterwards 9:05, 9:10, 9:15, 9:20, 9:25, 9:30. Like that you write, you have to write, and you say 120 by 80, 120 by 80, 120 by 80, whatever SPO to dispose, write that. It should be there. Your notes are going to speak for your care, not whether you took care or not. Your notes are going to be examined under the lens, under the microscope, by the opposite lawyer and the judge. In the cross-examination, Dr. Pinaben Shah, purportedly the senior anesthetist, says that in my opinion, if nothing is done for 4 or 5 minutes, it may not be possible to revive the patient. That's why this lady has not done in 40 minutes, the patient has gone. So appeal for doctors is rejected as negligence is proved, and appeal of patient is also rejected because compensation granted is adequate. So this is the classical case where doctors have spoken against each other. Doctors have, all of them have committed something wrong, and all of them said that we want to appeal, and all the appeals were rejected. And now we come to vicarious liability. If you are working as an employee of the hospital, then the hospital is liable. For example, in government hospital, surgeons and anesthetists are safe. In civil case, the master is liable for compensation, or employer is liable for compensation of the work done by. You have to pay for services or servants' mistake, like nursing staff, residents, etc., etc. So, what is the test for this vicarious liability? So, has harm been caused? Yes, the harm has been caused. What was the harm caused by your employee? Yes, the harm was caused by employee. Was the employee acting in the course of employment? Now, this is the most crucial question. The employee took my driver, took my car to get something from my office to my residence. During that trip, the driver had an accident and somebody was killed. So, during the course of employment, this has happened. However, my driver took someone else's car and went for his personal shopping, and at that time he hit somebody, then this is not vicarious liability even if I have employed him as a lawyer, as a driver. It is very simple for understanding of the last part of the slide. Was the employee acting in the course of employment? Like I was giving anesthesia in as per my duty on that day, I am liable. So now we go to the last part of ruminating. We have gone through introduction, prevention, all that part, communication, mitigation, and now we are at the, after litigation, we are coming to the rumination part. Let us see what is the carry-home message. Please document all efforts. You have to have emergency medicine box. Avoid prescriptions of emergency drugs. You should have rush team to come and help you. You inform police. You take collective responsibility. You follow protocol. You learn to communicate, and to avoid the payment of 4,20,000 or anything more than that, take insurance, which is very essential, professional indemnity insurance. Now we come to the psychological framework. As I told you, there are 4 phases of reaction. First is the kick phase, in which when the situation is there, you'll have a lot of emotions and their physiological manifestations such as tachycardia, sweatiness, agitation. You will start yelling. Control that. The severity of your reaction will depend on the age of the patient, whether a surgery was emergency or planned, what was relationship developed with the family, severity of complication. All those things will matter in the severity of your reaction. Like I said, a roadside accident, bled and came to the hospital, you will not feel very bad if the patient cannot make it. But a 32-year-old young woman coming for cesarean section cannot make it, then definitely the cause may be amniotic fluid embolism, the cause may be pulmonary embolism, the cause may be anything, but then you will feel very bad about it because you are also human being, you are going to have emotions, you are going to have reactions. So this is the first phase of the 4 phases of reaction, that the kick will be there. Then there will be a fall. So you'll start having counterfactual thinking, asking oneself questions such as what if, or what if only, was it my fault? And if the thinking process is in upward direction, self-focused, then it may help to improve your performance in the next case. That I should not make these mistakes, this is what I happened, I could have done better. But if it is downward, outward focus, somebody else must have done, cause was out of my control, then you start blaming somebody. And that is where we have to control that. If you start blaming, a surgeon starts blaming anesthetists in front of the nurses or the ward boys or the operational staff, then they go out and tell them that the surgeon said that the anesthetist has done this. The anesthetist, the surgeon should not have done this. That is the gossip that will go out. So first thing is you have to control this phase of reaction, even if you are in the fall phase. This is learning that even is bringing you control that situation, and no blame game should be there in the operation theater. Then the phase of communication, this is successful. You are able to convince the patient that you could do what is required to be done. You have taken all efforts. You have not left any stone unturned, but you could not make it. Then there is a recovery phase where you will become more calm, more reflective. You may have learned something from the event. It will prevent future occurrences. Most of the times, relatives always say that our someone else should not suffer from such a issue. But if that communication helps you to learn that, that is fine. Feedback for critical reflection, personal performance. It is effective, specific, directed, and task-oriented. And for negative feedback, psychological and neurocognitive mechanisms work in the body. Let us not get into that part because then then you are getting into the area of psychologists and psychiatrists, which is not my cup of tea. And in the process of mitigation, you will have certain long-term impacts because you are trying to mitigate something now. You will go through some identity dissonance, means that from the equally similarly situated surgeons or anesthetists or physicians, same group, you will feel that you are little lower than them or you are guilty or whatever it is. You keep on gathering information of how this could have been avoided. It will be difficult for you to concentrate, inability to focus, ability to think straight may be compromised. This will happen, but then this is part of the profession that you are working in. But the action for reducing the long-term trauma, the severity, seriousness of pain of something has to be taken at that time. Whatever may be the consequences, they may be rectified later on, but the financial and legal consequences which you may go through should not be there. You should not be required to suffer those for which you have to do all that is told in mitigation section. And then litigation. The strong emotions evoked by complication become imprinted in the memory, having the potential to influence decision making in subsequent cases in which this memory is retrieved unconsciously. So you will keep on thinking about it. And there may be second error and there may be third error. There is a tension between needing to appear strong and actually being strong. When you face the lawyer, are you really strong? Or when he starts asking questions, are you going to go down? Reactions were not getting any better or easier to handle gradually with time, especially when there is a cumulative effect. You had a first case, then you had a second case, then you had a third case. Then there are some statements from the victim, then you will realize how it works. That he says that I remember all my deaths. I remember all my deaths. We all have our own graveyard. We have so many patients who have expired under our hands during our treatment, then that cumulative effect will become very traumatic. And believe me, if you get into litigation, this cumulative effect of one case also will keep on torturing you every now and then the case comes in the court. So better to avoid litigation and cumulative effect or long-term impact thereof. However, every time you will not be in a position to avoid litigation. So it is better to prepare the litigation phase during those 90 minutes. So I come directly now to the problem statement. Anesthesia is a high risk specialty as there is very thin margin of safety. Anesthesiologist has very little interaction with the patients and patients' relatives. They don't know you, they have never seen you. So I was very happy the other day when the senior anesthetist came and talked to my father when he was 87-year-old father, he was undergoing some surgery. So before surgery, he came out and talked to my father, talked to us, and we knew who was the anesthetist and who was going to do what. He said that I'm going to give you a saddle block, it's a small procedure, and then we were told how it is going to be done. And my father was also told. That is how it should be, that the anesthetist has to interact with the patient and patient relatives. Public is not at all aware about the role of an anesthetist, type of anesthesia, what are the risks involved. So invariably, in case of peri-operative death, the anesthesiologist has to bear the brunt of such mishap. Very unfortunate, but it is so. Hence, the patient's relatives react in a very hostile manner towards the anesthesiologist, and many times they seek redressal in police station courts of law. The ability to think clearly, gather and process information at the moment of crisis can be jeopardized by consuming thoughts and emotions associated with the ruminating of a previous complication. And the anesthetist, it may not be possible for him to consider of early retirement of changing scope, especially younger ones who are in the beginning of the careers. And the the change of profession may not seem to be an option. And then we have to think of long-term measures, because the uncertainty of medicine in parallel with unacceptability of error are the two diagonally opposite things in which we work, and we are forced to work in this situation. The competitiveness of medical practice, belief in physician, we can control everything, belief that we can control everything, and basic principle of first do no harm. All these play on our mind in the long term. So what is required is support measures for physicians undergoing distress from adverse events, changing the culture in which adverse events are understood. Is there a mechanism in which we can share an adverse event which happened in our hands? Whether patient survived or died is immaterial, but whether people are going to look at it as a mistake or as a learning curve or as a negligence. Currently, unfortunately, nothing, no learning is gained from such episodes, and that culture has to change. So, mindful practice, defined as conscious and intentional attentiveness to the present situation, is essential. So, you have to attentive observation about your work, critical curiosity of what you do and effects thereof, work like a beginner every time and in presence, and reflective abilities at the moment and personal well-being. And please note that you are not alone in these reactions. There are studies and studies and studies which talk about these psychological problems faced by anesthetists, surgeons, physicians, pediatricians, everybody who has gone through such trauma as the second victim, as I described in the beginning. So, most important thing is establishment of support systems, trust teams, the senior doctors from the institute, your friend circle, professional association, IMA, local associate doctors, medical legal group, and anybody else who can help you. You should have a continuous rapport with them. And for this reason, we are starting this Medicos Legal Association, for which you can subscribe by sending email to this Gmail group, and you will be added to the group and will keep on getting continuous feedback. Thank you so much for giving me opportunity, Dr. Chandolkar, to talk. And
Thank you, sir. Very informative lecture, sir, and we learn a lot from you.
thank you so much. I'll just have a
I
glass
will.
of water.
Yes, yes, sir. Take, sir. Dhananjay, you want to ask question?
Please go ahead, shoot.
झालं की नाही तुमचं
I think I was able to finish in time.
Yes, Sachin. Sir, Joshi sir, I have a question.
Yes, sir, please go ahead.
Sir, in your talk, you suggested that if suppose he's an 82-year-old man having some carcinoma or something, and you can, for that death on table, you can give death certificate or cause of death. But my question is, if suppose you give cause of death and later some relative complain that that was a surgical negligence and my father's aorta was cut,
Hmm.
how does it work? Does that undertaking or video consent valid in court of law?
Now, these are two parts of the question, whether the PM was done or not.
Yes.
If you have said that you offered the PM and patient refused to PM and they gave the consent and all those things happened, then patient would not really be in a position to say that there was pitting of aorta and death due to that. Now, where from this question of injury to aorta come, it will decide the answer to your question.
No, my question is, suppose someone is having two son present with you giving consent, and
Hmm.
later on third son comes and goes in court that
Hmm.
he seems it to be negligent.
Hmm.
that does that video consent or undertaking is valid in court
And
or not?
two major people have given consent. You
Yes,
cannot ask all family members to come and sign. It is not possible.
yes.
It will be taken as a valid consent. Patient's relatives are
No,
accept
my
for that.
question is not that, sir.
Then
My question is that undertaking or a video consent given by the present relatives at that situation, is
hmm.
it valid in court of law if some other relative complains later on, or
No,
it is not?
if he complains that there was a rupture of aorta or cutting of aorta, he will have to prove it.
Anyone. That was just for example.
Yeah, but whatever allegation he wants to make, he will have to substantiate the allegation, and then you will have to prove that that was not there. I agree that you will have to prove something,
How can
but
we,
based on allegation, that allegation has to be proved, no?
sir, my question is how can we prove it when the body is buried or burned out?
So he also cannot prove. So
But
you say now your notes will be taken as a standard. Whatever you wrote before that event, before the allegation was made, will be taken as a standard note. It will be taken as a truth.
that means that
So
undertaking is valid in court of law.
not only undertaking your notes, in your notes, if you have written that the aorta was ruptured, in your notes, means surgeon's notes,
Yes.
then it will be valid. If it is
Okay.
not written, if it is written that surgery done uneventfully and then cardiac arrest happened, then that will be
Cumulative,
the truth. That will be the truth.
shall we take it as cumulative paperwork and undertaking will be valid in court?
It will be valid in the court if it cannot be disproved by post-mortem.
No, no,
That's why I
postmortem is
said,
not done, sir. In this case, postmortem is not done, and we have taken
so
undertaking.
finished. Your notes will be final notes.
Okay, that is valid, you mean?
Basically, I will tell you, doctor's notes are experts' notes which will not be challenged unless there is a gross discrepancy between two notes.
Okay,
Now, assistant surgeon writes that there was a small injury to aorta.
okay.
Suppose, suppose,
Ah,
and surgeon says that nothing, no problem. Then obviously there is a difference, no?
okay.
As long that's why I said those 70 minutes, 90 minutes, you have to have congruency amongst yourself.
Paperwork.
Paperwork should be perfect.
Okay. My one more question, sir, to you is
Please go
while
ahead.
taking consent for surgery or for anesthesia, specifically for anesthesia,
Yes.
what I follow in my hospital,
Hmm.
I have printed consent in local language, Marathi.
Okay.
The two who can sign that consent, what are the types of anesthesia, information regarding that type, for
Yes.
example, general, its complications, regional, its complications, and
Yes.
uh, in blank page, in that consent only, I kept a few lines, 10, 15 lines blank,
Hmm.
where I write patient specific or procedure specific complications or problems in that consent.
Correct.
Is
Correct.
that valid or everything should be handwritten?
Okay. Now this is very important question which you raised, and let me give a little detailed answer.
Yes.
The courts have said that pre-printed stationery and consent on that is not good in law or is bad in law. That is what courts have said. They have said that every consent should be a patient-specific, procedure-specific consent. Not only that, they have said that patient should get adequate time to read it
Hmm.
because you are asking the patient to sign on dotted line and patient doesn't have knowledge of what was written.
Hmm.
To that extent, court have gone. But it is not practical also. So
Yes.
what you are doing is correct that on those lines, basically what I find is that many hospitals use pre-printed forms since they don't write one patient's name, they don't write surgeon's name, they don't write anesthetist's name, they don't write any procedure specific complication, they take only signature. That is 100% wrong. Okay. Now what you are doing is much correct, much more, uh, towards align with the law that you write the possible complications of the procedure. For example, you say LSCS with a previous LSCS, there is possibility of cutting of the ureter or something like that. Whatever you write,
Anything.
yeah. So that is correct. Now, question will be one more, that you have taken the consent just before the surgery, right?
Yes.
So for planned surgery, it is possible to give 1 or 2 days before. But for emergency surgery, it is not possible. For example, you do LSCS for a patient who comes in labor.
Hmm.
For even if previous LSCS planned, if it is planned, okay, you will give 2 days time. If it is emergency, then what will you do? So these things have to be explained properly to the court. And from my personal side, what I am trying to do now, I will take your feedback on this. That I am trying to develop a mechanism
Hmm.
in which patient's details will be selected, like what risk factors are there.
Yes.
Procedure will be selected, and procedure specific risk will be there in that. For example, LSCS only and LSCS for previous LSL will be two different texts for two different procedures.
Yes.
Okay, something like that. And all that will be printed, or all that will be sent by email to the patient 2 days before the surgery. And the patient will sign electronically that I have received this document, and bring that printed sheet to the hospital when he comes for the surgery. So I'm solving the issue of 2 days in advance, the patient specific, procedure specific, anesthesia specific consent in electronic format, and the duration also. So do you feel that that would be a better solution?
That is better solution, but practically little difficult in our
Practically
area
difficult.
or
Correct.
anywhere in my
Practically
India. It's little difficult unless
Yeah.
it's a corporate setup.
Correct. Correct. So
Because
all
we
those things,
do
I
not
mean,
have that much
there is
man.
no straight answer to this, but something will have to be worked out. And what you are doing is correct, that you are writing something, at least 2 lines, that in this case I have told patient that this is the possibility, and patient has signed in Devanagari or Marathi script. I think that is should be more than sufficient in your
No,
case.
no, my question is not that. So my question is whether that is valid, because you said pre-printed consents are not accepted.
That is the problem. It is court will take a view based on. I tell you what will happen in the case. What has happened and what was written. If there is issue, I mean, courts are also not experts, right?
Yes,
So what I would say is that it is impossible to write by hand every.
everything.
Now I can take a name. One Dr. Raghunath Golwal is there in Pune. He asked the patient to write down that text himself and sign.
Yes,
What your pre-printed stationery is there, he has prepared a, what you can say, envelope in which he has kept it,
and
and
then
then
he has to write it down in his
you
own
write it
handwriting.
down. Relatives, he gives a full script notebook, you write it down and sign.
Yes,
So you don't spend your time. The
yes,
patient relatives has written in his own handwriting,
yes.
and then he takes signature on that
Written.
printed also. Printed also. So I mean, now this is something which he's doing, but whether practically you can do it or not is a,
Practically, it's little difficult, sir,
it
because
is
consent,
difficult.
what I feel or what I think, consent is a contract document between a doctor and a patient or relatives.
Yes,
And it should not be only procedure specific. It should, in case of anesthesia at least, it should mention general anesthesia, uh,
yes.
what is basic general anesthesia, complications, what type of procedure, all other type of anesthesia, regional, spinal,
But as I said in my presentation, the anesthesia sheet should be separate. But
yes,
then there are no many different complications of general anesthesia. There are standard complications of spinal
but I
anesthesia,
am asking
standard complications of regional
whether
anesthesia.
that fixed format can be printed.
I think so. For anesthesia, consent should. That is what I said. Procedure consent should be separate. Anesthesia should be consent should be attachment to that consent.
Yes. Okay, sir. Thank you.
सर
धनंजय
आय वॉन्ट क्लोज सर येस येस
क्वेश्चन आहे का?
हा माझा एक क्वेश्चन आहे सर सर
बोल.
Yes.
फॉर consent paper we are taking consent from patient,
Yes.
should we need any witness on with patient's signature,
Yeah.
with
Yeah.
witness
Two
signature?
two people should sign consent. Relatives. मॅन्डेटरी आहे. आमच्या फॉर्म वरती आहे ना, 2 रिलेटिव्ह आहे ना.
Other than relatives, any witness as like
Not
that?
necessary. 2 relatives is okay. I mean, it is impossible to get one more relative and then take his signature. It's very difficult.
Okay. हा धनंजय नंदनकर सर. Please ask question.
Sir,
Yes.
if there is a death on table and we
Hmm.
are not able to diagnose what may be the cause of death,
Yes.
and the relatives are not willing for doing PM,
Hmm.
then at what that time, what should be our stand?
Yeah. So there was one slide in which I had said that you have to tell them that we don't know the diagnosis, so we cannot give death certificate. If you
And
know the
if
diagnosis, if you know the diagnosis, you give death certificate. If you know the diagnosis, then also you can advise or offer postmortem to the relatives. But if you don't know the diagnosis, do not give death certificate. I will tell you the reason. You give death certificate and afterwards they take for the postmortem. Just now they are saying that we don't want postmortem. Then they take the body home and then they go for postmortem. And something else is revealed. Then you are in a big soup.
yes,
So don't try to help, go out of the way and help patients. Never do that. Now, if you want to, if they still insist, then you tell them that okay, you go to the police. Police have got this power of giving death certificate and you know sending the body for cremation. They can do it, but you have not signed that document.
and if they have done the PM and they have not got any exact cause and
Yeah,
PM also,
yeah.
then sir,
What can they do?
and they will litigate. No, that yeah, there is a death. So
No,
and if
what is they will litigate not for death. They should not. They will litigate for your negligence. They cannot litigate for death. Everybody is going to die.
okay,
How can they say that you were negligent? What is the reason for which they will? Only for death they cannot go to court. No, there are so many judgments that only for death doctors cannot be held responsible. I can give 10, 20 judgments like that. That is not the issue. Issue is why they are saying that you were negligent. For example, in postpartum hemorrhage, you did not arrange blood. Not even one bottle of blood you arranged. That is negligence. But if you have booked a blood and you have given them a check to get a blood from the blood bank, you have done your job. What else you can do? Then there
thank
was
you.
one judgment in which a gynecologist said that internal iliac ligation should have been done, hysterectomy should have been done. All those things are the doctors giving opinions against the doctors. But basic thing, if blood is only not arranged, what can be done?
Okay, sir. Thank you, thank you.
Thank you.
Dhananjay?
Jayati Ghosh, madam, please.
Yeah, I have one question.
Yeah, please go ahead.
Um, it is said that if possible, you should not declare the death on table. You should take patient to the ICU, and afterwards you declare death in there. Is it? What is the benefit of that?
Actually, I showed in one of my slides that there is not much benefit, but still that psychological mindset of people is operation table पर गया डॉक्टर का गलती होगा. That is avoided and the patient is, the patient is there in ICU for 2-3 hours, then the patient died. That is little more acceptable to the patient was serious and then was taken to ICU and then the patient died is more palatable to the patient than saying that the patient or relative than patient died in the theater. That is only thing. Legally,
Oh,
there is not much of a difference.
legally?
Legally, there is not much of a difference. The
Okay, okay.
procedure to be followed will be same. For example, I will give you one example. A patient is a serious patient who has come to ICU.
Yeah.
A medical cause. Medical cause. Okay. Patient's relatives are ready that the patient is serious and maybe there is some problem and patient has to be taken to ICU and he may not make it. Now
Yeah.
the patient came walking, went to the theater and then died. And patient came walking, then went to the ICU and then died. So there is a time
Yeah.
gap in which the mindset can be little more prepared for the death or consequence, which is not there in the OT. That is the only
Okay.
difference in the mindset of the relatives, not medico-legally. Medico-legally,
Okay.
we have to go through same procedure.
Okay. 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 Yeah. Thank you. Thank you very
Thank
much.
you.
Dhananjay? Dhananjay, you have a question? You raise hand.
सचिन, मला वाटतं त्यानं ते आधी हँड रेज केलेला आहे आणि तो तसाच राहिलाय.
तेच राहिलेत,
हा
हा.
हा 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 I think so.
येत नाही.
But
हॅलो हॅलो
हा
हा,
हा
बोल
हा
ना.
हा
Hello.
Dhananjay, come on. Yes, okay.
सर मॅडमचाच क्वेश्चन adding madam's question,
Yeah,
if the patient is having some anesthesia related problem, we
yeah,
shifted the patient to ICU.
yeah.
If patient is there in ICU for more than 24 hours
Mhm.
or something 1 to 2 3 days and then
Okay,
patient died,
okay.
then is there any need to do the PM? Because what I thought, 24 after 24 of hospitalization, you are supposed to come to some diagnosis,
Hmm.
so you can give the death certificate. If
Yeah.
so, is there any need to go for the PM after more
The
than
word,
24 hours?
the word which you use, supposed to know, is very important. Supposed to know is very important. If you know, you give death certificate.
Okay,
If you don't
okay,
know, if you don't know,
okay,
don't give death certificate. Now,
okay.
the question will be that patient is there in ICU, relatives are also saying, "दे दो यार, हम लेके जा रहे हैं,"
Uh-huh.
and you give death
Okay,
certificate, and in PM something
okay,
else is found which you missed. Okay,
okay,
then you will be in a trouble. So
okay,
always
sir.
better
Better to.
that if you know diagnosis, give it. Nothing. No rule is there that postmortem should be done, pregnancy should be done. There is no rule like that. Rule is
Okay.
there when you don't know the diagnosis. In accident cases,
Or
in tumectomy,
our
there is a
or
list. There is a list in law
yes.
which I am not going to go into those details, that in which cases postmortem has to be done. But we are just
Okay.
talking about anesthesia related deaths. But if you know the diagnosis, you can give the death certificate. If you don't know, don't give it.
If you are in doubt, better way go for the
Don't
PM.
give. Go for PM.
Okay. Okay. Okay.
I have
Thank you.
learned in 30 years of my practice that don't go out of the way to save patients' money and avoid some investigations, save patients' trouble and avoid PM. Don't do that. You tell
Right.
them, I want
Very
this
true.
investigation, go get it from government hospital. I want this lab
Right.
report, go from charity hospital. I want this report. I can't
Okay,
do
sir.
it without it. Go and get postmortem done. Then, if they give letter, then they go to police. Police says that don't do it. Fine. Then you are
Okay.
forced not to give it, right? Forced. Then police can ask them to do the cremation on their own. Or
Okay.
police can tell you that give death certificate, Doctor Saab, of
Okay.
their term.
They are not willing.
They take it from them in writing that there's a death certificate. There is no complaint.
Okay. Right. Right. Very true, sir. Thank you, sir.
Thank you.
Sir, one more question.
Yeah, Dr. Dande sir, namaskar.
Sir, namaste. Sir, police have only right to order PM or not to do PM. Do they have right to issue death certificate?
No. They don't have right to issue death certificate. They can request you कि कोई complaint नहीं है, आप दे दो death certificate.
Then we have
Order
to take
नहीं.
it from in writing.
I mean, if you see, the question is afterwards they only will go and do PM. Then
we
we
will
will
be
be in
in
difficulty. So better to avoid that. Then if they are definitely going to take to crematorium and do the rituals, then there is no issue. But they will take death certificate from you and then do PM, and then there will be a problem. Then you are the one who is going to suffer, no?
Yes, sir.
And cases have happened like that.
Right. Yes, sir. People insist कि हमको कुछ नहीं करना है, and then police says कि अरे बाबा ठीक है जाने दो इनको डेथ सर्टिफिकेट दे दो, And later they again blame कि आपने नहीं बोला था फिर भी हमने PM कर लिया, and then we have already issued on request of police.
Yeah,
That becomes a problem.
I agree. But somewhere we have also stopped.
Yes.
I mean, practically, police is saying that they वो लेके जाएंगे. So I mean, you will also realize who is playing mischief. In that case, you say, okay, 2 doctors should attend the post-mortem, do the video recording. You also apply.
Yes. Yes. Once I asked the police की ठीक आहे मी देतो तुम्ही मला लिहून द्या की मी सांगतो म्हणून तुम्ही डेथ सर्टिफिकेट देताय. They told नाही ठीक आहे बाबा तू PM करून घे म्हटले.
Who wants to take responsibility?
Yes. Right. Thank you, sir.
Yeah. Thank you.
Yes, sir. Nitin Nandanwalkar, sir. Will you have a question? Yes, sir. Please.
Sir, if there is a post-operative death within 24 hours,
Okay.
and there is no any surgical cause, is the anesthetist held responsible for that?
Is it related to anesthesia, or is it related to septic shock, or is it related to...
No.
What is the cause?
If the cause is not known,
Cause is not
is the
known.
anesthetist held responsible for that?
Why should anesthetist be held responsible? Post surgery, there could be septic shock. Post surgery, there could be internal bleeding. Post surgery.
If there is no any surgical cause, then, sir.
Then how do you know? You don't know the cause, no?
Sir, means basically ASA grade 1 patient. Sir is asking. ASA grade 1 patient and operation uneventful.
ASA
Grade 1, grade 2 patient.
ASA
grade 2
1
patient,
was
I
before
suppose.
surgery. Sir, ASA grade 1 was before surgery, okay?
Okay, sir.
You are saying 24 hours after surgery, surgical cause is not there. How do you know surgical cause is not there?
No,
How do you know
if you are
anesthetic cause is
excluding.
there? How do you exclude?
Okay. In post-mortem, if it is diagnosed that it is not a surgical
Means
cause,
you
it
don't
might
know,
be a
no? You are
cardiac
saying
arrest.
for post-mortem.
No, cardiac arrest or
Cardiac
something.
arrest after 24 hours. Cardiac arrest after 24 hours.
Within 24 hours. Within 24
Within
hours, sir is
24
asking.
hours.
Okay, I understand within 24 hours, not on the table. No?
No.
Not on the table.
So how
Everybody
many?
is going to, sir, everybody is going to die after the cardiac arrest at the end.
No,
Very
he is
true.
anesthetist is responsible for that.
How
If
can
there is
he
no
be
surgical
anesthetic?
cause in the post-mortem also.
How will be anesthetist responsible?
As,
That's why I'm asking.
sir, as many surgeons says कि it's a responsibility of anesthetist to take care of patient till 6 hours, till first
24 hours.
24 hours. It's your responsibility. Like they are saying. So is it legally valid?
MTP के लिए आप anesthesia दो 24 hours के साथ बैठो.
वही तो सर वही sir is asking the same.
He will also have to show why he is saying anesthetic death. No, I mean, definition wise, due to anesthetic cause in first 24 hours. So what is anesthetic cause? The patient has come out of anesthesia, patient was awake, the anesthetist shifted the patient to the room. Anesthetist notes say that patient is stable, BP so and so, pulse so and so, oxygen saturation so and so. The anesthesia has, I mean, the effect of anesthesia has gone. So how it is anesthetic death? Unfortunately, we have problem of blaming other. Okay. And then he doesn't want to be responsible, so he's saying you are responsible. That is not correct. No, that is the issue. In medical profession, the problem is that we have got so many branches. Surgeon hai, anesthetist hai, then government or doctor hai, private doctor hai, private doctor, general practitioner hai, consultant hai. So all those our internal cases are taking us down the drain every day. So we have
Very
to
true,
avoid,
sir.
we have to avoid those things.
If anything happen, mishap, firstly we ask who is the anesthetist. If some operative mishap happen, everyone asks who is the anesthetist.
Who
Since
was
this
the
is
anesthetist?
the
Who was the anesthetist?
who was the anesthetist?
He is not there now, no. He has gone to other place.
Yes,
He
reality
is
of
not there.
our branches. Yes.
See, I will tell you, you as an anesthetist know that the patient is not stable. Okay? You know that the patient is not stable. Still, if you leave the patient and go, then you are sure that you will be responsible, because everyone else also understand that this is because of anesthesia. But you are sure, you are honest to yourself that the patient was stable, patient was out of anesthesia, patient has recovered, PP normal, pulse normal, then okay. Some of my anesthetists friend, if there was a problem, they said 2 घंटे बाद मैं चक्कर लगा के जाऊंगा, देख के जाऊंगा patient को. That is also you do. I know that. Blanket statement that anesthetist is responsible is, I mean, don't go to that surgeon again.
Right
What
point.
else?
Yes.
है ना, बराबर है ना?
एकदम right points. Any questions from audience?
सचिन काटेकर मॅडम दिसत होते, वेलकम कर आणि
Yes. मॅडम आहेत. Just yes, madam, please.
मॅडम म्यूट आहेत तुम्ही.
Thank you, ISA team NANDED. Thank you, Dr.
Thank you,
Rajeev
madam.
Joshi. Also, there was some overlapping of programs. Unfortunately, I wanted to join this program. पण आता मी रेकॉर्डिंग ऐकीन आणि शेवटचं डिस्कशन मात्र मी ऐकलं आणि इट वॉज रिअली इंटरेस्टिंग. आणि सर, वी वुड ऑल्सो लाईक टू इन्व्हाइट यू ऑन द प्लॅटफॉर्म ऑफ महाराष्ट्र स्टेट चॅप्टर ISA. तर तुम्हाला मी नक्कीच थ्रू सचिन आणि कोटकर सरांच्या
madam.
परत
I will.
निमंत्रण देईन
Yes.
सर. I would be really happy.
Thank
you.
Unfortunately, there was overlap of 2 programs today. There was
Yeah.
a program of Maharashtra State and
I hope you get the overlap of your cases, ma'am.
it is like
God.
overlapping of cases.
Yes, sir,
Yes.
yes.
Then who is responsible will be a question.
Yes, sir.
Thank you, ma'am.
Sir,
Just joking.
Sir, yes, sir. Thank you so much. Thank you.
Thank you.
So kind, sir. Sir,
Sachin
as
sir,
per
तुम्ही
your age,
recording
you are.
available करा या program
Yes, madam. I will send
Yes,
share
sir.
with all our IC
Yes,
platforms.
Yes, sir.
madam.
Thank you. Thank you so much.
Thank you. Sir, मला लिंक पाठवा तुमची रेकॉर्डिंगची.
Yes, मी आपल्या legally qualified वर पण पाठवेल, तुम्हाला
जरूर,
पर्सनली पाठवेल.
जरूर.
Yes.
Thank you for
You are
inviting
so
me
kind,
for
sir.
this
तुम्ही एवढा
program.
वेळ दिलात. हा सर.
Thank you for inviting me for this program, and I am grateful to be associated with you.
थँक्यू सर, थँक्यू. आणि सरांचं मेडिको लिगल एड मध्ये फार मोठं काम चालू आहे सध्या IMA आणि महाराष्ट्र साठी. सर 2-3 केसेस फाईट करतात सध्या सुप्रीम कोर्ट आणि हाय कोर्ट्स मध्ये. त्यामुळे सरांच्या मेडिको लिगल एड ग्रुप मध्ये पण जॉईन व्हा. आपल्याला बऱ्याच
मी
गोष्टी
तुम्हाला ईमेल
करायच्या.
ऍड्रेस दिलाय, त्या ईमेल ऍड्रेस ग्रुपला तुम्ही ईमेल करा. आय विल गेट यू ऍडमिटेड टू दॅट ग्रुप अँड देन यू कॅन हॅव फ्रुटफुल इंटरॅक्शन इन दॅट.
येस.
Thank you again. Thanks a lot, everybody. Good night.
Thank you, sir.
गुड नाईट.
थँक्यू सर, थँक्यू. गुड नाईट.
आणि
Thank you, sir.
डॉक्टर
Thank
सचिन,
you.
तुमचं असोसिएशन काय आहे हे आता मला कळलं परवा.
मॅडम.
मला कळलं आता ते हाऊ यू आर असोसिएटेड.
येस.
थँक्यू सो मच. थँक्यू.
थँक्यू.
Shall I exit?
येस सर. तुम्ही वेळ दिलात आणि या एज मध्ये तुम्ही एवढा वेळ थांबलात आमच्यासाठी फार
Thank
मोठी
you so
गोष्ट
much.
आहे.
माझी मिडनाईट सुरू झाली आता.
येस सर. आम्ही तुम्हाला डिस्टर्ब
Bye.
केलाय माझ्यासाठी म्हणून तुम्ही
नाही ठीक